carcinoma before medullary carcinoma. Important notes that the role of radioactive iodine in medullary carcinoma, there is no rule for radioactive iodine in medullary carcinoma, as medullary carcinoma arises from C cell that cannot pick up iodine. Another tumor, which is lymphoma that form about 4% of thyroid cancer. The origin from lymphoid elements within the thyroid, and may be predisposed by Hashimoto's thyroiditis. The treatment by radiotherapy and chemotherapy, and the prognosis is good. Now let us talk about complications that may occur after thyroidectomy. First complication is hemorrhage. Hemorrhage may be due to slipping of ligatures. Commonly, the superior pedicle ligature that is most liable for slipping. It causes tachycardia, hypotension, breathlessness, and compression over the tracheum that may cause severe stridor respiratory obstruction due to tension, hematoma, under strap muscle. As a first aid, immediate release of suture, including that of deep fascia, has to be done at the bedside. That means at the ward, so that the pressure over the trachea is released. Then the patient is shifted to operation theater, and under general anesthesia, exploration is done and the bleeders are ligated. Blood transfusion may be required. The second complication that may occur, respiratory obstruction. These may be due to hematoma, collection of blood at the site of operation, or due to laryngeal oedema, or due to tracheomalacia, or bilateral recurrent laryngeal nerve palsy. In this case, emergency endotracheal intubation may be needed along with steroid injections, and emergency tracheostomy also may be required as a life-saving procedure. Another complication is nerve injury, which include recurrent laryngeal nerve injury and external laryngeal nerve injury. The cause of recurrent laryngeal nerve injury, either pressure on the nerve by edema or blood clot, or accidentally ligated. The manifestation, if unilateral paralysis, it will lead to hoarseness of voice and dyspnea, while in bilateral paralysis, it will lead to stridor and suffocation. Regarding the external laryngeal nerve injury, the cause is usually accidental ligation of superior thyroid vessels and injury to that nerve that was in this pedicle with these vessels. And the manifestations of external laryngeal nerve injury is loss of high-pitched voice. Another complications of thyroidectomy, post-operative thyroid crisis, or what we call thyroid storm. The incidence nowadays is rare. Why? Because of good preparation and control of toxicity before operation. Because the most common cause for this storm is poor preparation of thyrotoxic goiter before surgery. The manifestation include symptoms of irritability, muscular excitability, and may reach to convulsion, excessive sweating. Signs include hyperpyrexia that may reach up to 41 centigrade or more. Severe tachycardia that can reach to up to 160 beats per minute or even more. Arterial blood pressure, there will be rise in systolic and diastolic that may lead to heart failure. The treatment of this condition should be urgent. Yes, should be urgent. Include ice baths to limb, head, and abdomen to decrease pyrexia. Intravenous fluid, sedation by morphine, antibiotic to prevent chest infection, oxygen inhalation and intravenous hydrocortisone, beta blocker, mainly propranolol or its name called Andiral by intravenous drip in glucose water under ECG screen till pulse reach to normal. Also antithyroid drugs, which include carbimazole in a dose of 15 to 20 milligrams 6 hourly or liquids, and with the liquids iodine 3 cc in 1000 cc of glucose water solution. Another complications is the hypoparathyroidism. It is rare. Its percentage of 0.5% of thyroidectomy cases. Occurs in 2nd and 5th postoperative days. The clinical presentation of hypoparathyroidism include muscle weakness, which is the earliest symptoms of hypocalcemia, and also may present with tetany. First, there is circumoral numbness, then carbopetal spasm, and laryngeal stridulus. Also, there is positive Chauvastic signs on compression or percussion on the facial nerves. There will be spasm of facial muscle on the same side. Also, the patient may present with convulsions. The causes of hypoparathyroidism is either removal of all parathyroid gland or interruption of their blood supply. Treatment of hypoparathyroidism. First, we have to check and estimate the serum calcium. If the hypocalcemia is confirmed, then we have to give 10 ml of 10% calcium gluconate intravenously 8 hours. Later, we should give supplementation of oral calcium carbonate 500 mg 8 hours. After 3 to 6 weeks, the patient should be admitted and the drug is stopped and serum calcium level is repeated. Also, another complications of thyroidectomy operation is hypothyroidism. This occurs when there is removal of too much thyroid tissue and should be treated by the thyroxine replacement therapy. Another complications is keloid scar, and it is treated by this occurs especially when the incision overlies the sternum, and it is treated by steroid injection. Also, wound infection and stitch granuloma formation, another complication for thyroidectomy. Recurrence of hyperthyroidism because either of inadequate removal or hyperplasia of the tissue that has been left. Let us now discuss another thyroid gland disorder, which is hypothyroidism. The etiology of hypothyroidism, either due to failure of normal development of thyroid gland or due to dyshermogenesis, like that occurs in Bend-Reed syndrome when there is deficiency in peroxidase enzyme, or when there is no thyroid stimulating hormone, failure to secrete thyroid stimulating hormone, like that occur in Sheehan syndrome. There will be failure of TSH secretion from anterior pituitary, or due to primary myxedema, which is supposed to be an autoimmune disease and it may be associated with Addison disease, or it may be heterogenic, like that occur, the state that occur after subtotal thyroidectomy or radioactive iodine treatment, and in late stages of Hashimoto's thyroiditis. The clinical picture of hypothyroidism. Hypothyroidism in infants or children lead to a state we call it cretinism, and in adult the term myxedema is applied to severe cases of hypothyroidism. In cretinism, all parameters of normal development are impaired. The infant does not grow properly, he is stunted, slow to develop his teeth or to walk, The child has an apathetic look with depressed nose, thick lips, and thick protruding tongue. The abdomen is distended, we call it both belly abdomen, and there is usually an umbilical hernia. In myxedema, symptoms of lethargy, weakness, loss of appetite, putting on weight, and intolerance to cold weather. We have to remember that any pathological obesity or any obesity, we have to consider one of the causes is hypothyroidism. On examination, the patient looks apathetic with a sluggish reaction. The face is puffy with supraclavicular pads of fat. The skin and hairs are dry. The hands are cold. There is bradycardia with low volume pulse. The voice of the patient is coarse. Pericardial effusion, carpal tunnel syndrome, deafness, and ataxia may be present. In myxedema, the symptoms are nearly opposite to those of thyrotoxicosis. The investigations that required, we have to do thyroid function test. We will find T3 and T4 levels are low. TSH is markedly raised. The treatment is by replacement with L-thyroxine, 0.2 to 0.3 milligram per day for adult is satisfactory. Very early treatment of cretin in infants may save these lives. Otherwise, the changes are irreversible. The complications of myxedema include coronary thrombosis due to hypercholesterolemia or COM, especially when exposed to stress. Now I will talk about one of important subject in thyroid disorder, which is